Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to the Bone. Today's guest is Tim Nicolello, and he's an athletic trainer and president of the Athletic Trainers in the Physicians Practice Society, and he's also the director of network and program development for Assur Partnership Services, OPS, in Idaho. So with a background in clinical practice, residency education, and healthcare leadership, Tim has been the forefront of advancing the role of athletic trainers in physician practice settings. We're excited to welcome him to the Bone to share his insights and leadership, collaboration, and future of healthcare. So welcome to the show, Tim.
Thanks, Shelby. Thanks for having me.
Yeah. So we actually connected because I was on another podcast and dropped that I was from Alaska. And Tim reached out, I think, through LinkedIn and had to say that he was from the Valley, which, population that comes out of the Valley.
Time out. The clarification was I wasn't part of the Valley. It was very close to it, but I was not part of the Valley. That was the difference. But yeah, you're right. You're in Alaska. I'm from Alaska. It's a very small world that way. Yeah.
Yes, of course. So, while we get into this, being from Alaska, it's a small state of population at the end of the day, and athletic training is still emerging. I mean, I'm in Kenai, and there are athletic trainers, but not athletic training positions for employment down here. But what got you into athletic training, and what is your favorite part about it?
Oh, that's a loaded question. This is going to sound, I don't know what it's going to sound like, but being that I grew up in Alaska and there are ATs now, there really wasn't much of an athletic training presence when I grew up. And so, played high school sports in the early 2000s, and there were some ATs, but a lot of them were like PT, AT credentialed. There wasn't a lot of like traditional ATs working ATs working in that normal kind of setting or approach that way, that model. And so like our sports medicine team, if you want to call it that, was a PT, a family practice doc, an ortho surgeon, and a chiropractor. And you didn't know who was showing up that day. And kind of like, just like you got there for the game. And if you got injured, it's really more or less to make sure you weren't going to hurt yourself any further before they put you back in. It wasn't the true healthcare model it is today, but it's also kind of been a good progression as well. So, when I went to school initially, I went to this school called the University of Mary my first year in college to play football. Not a shout out, but a great experience. It was just a small little D2 school. And I saw athletic training as a major listed. And I was like, oh, athletics. Let's figure that one out. That's up my alley. And so didn't know what it was, to be honest, when I joined it. And then I started got some exposure to it. And then I transferred to the University of Idaho, which is where I went on to actually complete and finish my undergrad, AT degree, and kind of fell in love with it once you're in it, And so I kind of learned to love it, and then have kind of taken what that taught me and have applied it to a lot of different other settings, not only within my career, but personal settings and personal experiences at the same time. So
yeah. Well, so for listeners that might not be familiar with what exactly the Athletic Trainers in Physician Practice Society is, how would you describe it to them, and how did it start?
So it's exactly that. It is a society for ATs who either are interested in working in a physician practice setting. Traditionally, orthopedics has kind of taken over the majority of those setting opportunities for employment, but it is expanded, rheumatology, emergency medicine, physiatry, family practice. And so it's not just orthopedics. That's why we call it physician practice as a whole. And so, for probably in the mid 2000s, it started to become just a quote emerging setting. I would say we fully emerged, and there's nothing emerging about it at this point. It's just growing. And for a long time, we had support. It all kind of was under the umbrella of the NATA at one point, and as the demand for this kind of information and access to how to not only get involved but how to make it a career came, so the demands of support from an organizational standpoint that was needed, and it just came to a point where we needed more, and so we created it ourselves essentially, and so that was born officially. I think we started the charter and the policies and procedures and the bylaws, and technically the bank account opened up in like November of 2017 or so, and here we are almost 10 years later. Coming up, we're going to hit our 9th annual meeting next week, and then next year will be our 10th annual meeting, which is crazy to have been doing it for a decade that way. And so, our whole goal is to elevate ATs who are interested in this setting. That's the bottom goal, and elevate the profession as a whole by doing that. And so, there's a lot of different societies that have continued to be created and evolve. The NATA is evolving. There's a lot of organizations that are evolving to help support the AT profession. And I think in the end, as long as we're all doing that as a collective, everybody's going to rise together. It's not a matter about competing with one organization or the other. It's about collaborating and making sure that the profession itself raises together. And so, initially it started out with an annual conference. So like, hey, we need to get some focused content for anything and everything physician practice related. And so, our first meeting was in Boise, Idaho, which is where I live. So that was convenient for me. But I think we had a little under 100 people there. And now, we have a couple hundred who attend the meeting, and we're approaching nearly 1,000 active members, and it's growing year by year, and so is the demand for the employment of ATs, and there's further questions that obviously come on. Job descriptions are going to vary from employer to employer. Physicians are going to have different expectations based upon what they know or don't know with how to use an AT. So it's constantly trying to give insights on how to set yourself up for success and also future opportunities. And then even to not only from like a surgical assist standpoint and giving information around how to get in or how to continue to evolve, but kind of getting into healthcare administration and the management of healthcare, not just the management of patients directly, but it builds upon each other from a foundation. And so, our conference is next week. So if anyone's going to hear this before next week, hey, come to Cincinnati. But if not, we'll be in Atlanta the following year. But this year we're going to offer 27, almost 28 CEUs for this in-person event. And we record everything. And so if you're there in person, obviously you can't go to everything, but you get access to everything after the fact. So you go to everything in person, and then all the things that you didn't get to go see because you had to prioritize, you have access to all the recordings afterwards, which I think that's a high value item for people who attend the meeting specifically, because it's hard to be like, hey, I want to go to all 3 presentations, but they're all at the same time. And so we still have the opportunity to go back and be a part of it to some degree. And so that's the biggest driver of value. It's content that any AT within a physician practice employment setting can take back, anywhere from kind of beginner to intermediate to advanced to like healthcare administration. We have different tracks that kind of go with it. We have different workshops that occur before the conference starts. And so, trying to hit on all the value points for somebody's day-to-day job, but also setting them up for their future job opportunity is also the other goal in this.
Yeah. Well, I know that when I was at Pennsylvania Hospital in Philadelphia, we had athletic trainers in the orthopedic group. We kind of were on the MA trajectory.
Yeah, fair enough.
I
think it's common. Yeah.
Yeah. They were still trying to grow the position and, get the higher ups to understand how valuable the athletic trainers were. And I think, being in the environment, we definitely sold the physicians and they were definitely on board. But when you're talking about like the conferences and the continuing education that you provide, does the society also provide resources to help elevate in the hierarchy of the hospital,
Yeah.
or even for hospitals that want to start integrating athletic trainers? Do you guys come in and help support those advocates that are trying to get those positions created?
Well, coming in and helping probably isn't exactly what's happening. This is still a volunteer basis, so be able to go in there and walk somebody through, from a consultant standpoint, isn't happening yet. Maybe in
Okay.
time. There's definitely an opportunity for that, whether somebody wants to start their own business doing it or not, or if it's a society thing. I think it's part of a future kind of vision to get to. But we do work to put resources together to help, and so a couple different approaches. One, we have resources and research that's been out there that's directed towards administrators hiring to give them kind of the business model, because there's a couple different ways to consider the business model. One is how you gonna make us money to cover not only your expenses but help make the business money, because in the end it's still a business, right? The
Yeah.
other part of it is like, how satisfied are the physicians around you and the patients that you are caring for or helping care for by being in there? And you can make a case for either way. And so there's research in adding ATs to the staffing model and calculating how many new patients would it take to cover that employee, that AT's basically benefits and salary, to then
Hmm.
cover costs and then hopefully make money. So in orthopedics or healthcare in general, Medicare is kind of that base reimbursement line. And there's a study out there that we did that shows, if you even adding 3 new patients a week can cover, depending on what it is and what you're doing, can cover a minimum the salary and benefits of that AT. And that's only 3 new patients a week. And there's more opportunity to see more patients than that. And so once you kind of hit that threshold, everything beyond there is adding to the business, not taking away from the business. So people focus on, well, I need to be able to bill for my services. Well, in this role, there's no real place to bill for your services because you're working alongside either a PA or a physician who's billing for their services already. So you can't double dip.
Hmm.
So you're like, how can
Yeah.
I help make them be more productive, which makes the business sense, the model work. Then there's the other part of it. Sometimes there's physicians who are working at the highest that they want to work. Like, they are capped out. Like, they can't see any more patients, but they're also there, um, uh, you know, an hour and a half, 2 hours after clinic doing their notes, right? Or other administrative tasks that have to be done as a part of their role. Well, there's also been research to show that, like, you can bring in an AT to help do that, help with the documentation, help with the clinical logistics. And so when they're walking out of clinic at 5 o'clock, they're walking out with no charts to be done, whether going home to do it or staying in the office to do it, right? So their quality
Yeah.
of life is now increased based upon by bringing them in. So it's kind of a dual approach. And obviously, if you can do both, right, bring in new patients, increase volume, but also go home in a reasonable time, like that's the try. It's not really trifecta. That's whatever 2 would be. That's what that is, because it's not 3. But like, it's that's those 2 hit together, those intersect. That's where it's successful for the AT. It's successful for the business model. I think that the part you mentioned about the model, like an MA, that just takes time in understanding kind of what the capacity is. Obviously, we as ATs know that our capacity is much higher, and a lot of us have the
Hmm.
drive to do a lot more. So we're looking for the opportunity. Um, it takes relationship building with your physicians and your administrators. It also takes understanding your state licensure and scope of practice, right? What you can,
Yeah.
and literally what you can't do, right? Idaho is very fortunate. There's not a lot of things that says I can't do something. And so from there, it's a matter about creating the guide rails within your institution to allow you to do the other stuff. So if that's scrubbing into surgery, that institution needs to create guide rails on who's qualified, what sort of parameters are needed to have minimum qualifications to step into the OR, and then what sort of ongoing training might need to happen at the same time, right? And so that's going to be institution to institution within the same state, and then of course when you cross state lines, you can give perspective, but it's never going to be the same either. Right. And what somebody calls an AT in the clinic in one state or one place, they have a different name for it somewhere else. Right. I think a lot of people know the physician extender term because that's what it evolved from. but we are all ATs at the same time. We might be
Mm-hmm.
working in a capacity of what you would traditionally call a physician extender, but that a physician extender can be an MA, a PA, an NP, anybody who's helping provide services in extension of the physician, right? So we try to get away from that term. We are ATs and we're working in that job. We're an AT. It is what it is, right? And so it's not about having a different title. It's actually embracing our current credential and our current title, our profession. And it takes time and it takes people learning and being around it and seeing all the good things that can happen.
Yeah. No, that was great. I guess, what are your thoughts on the specialty certificates that are coming out from the BOC? And I think
Yeah.
NATA is starting to kind of dabble too. Is this going to help, or does this kind of compete with anything that you guys are doing for your population?
It doesn't hurt. Put it that way. It doesn't hurt. But, I think the BOC, so the BOC is the one who's really doing the credentialing of this, right? The NATA is a membership
Mm-hmm.
organization. They help support an alignment, right? Just like how ATPBS is supporting in alignment with it. But it's the BOC who's really like putting out this credential. And there's certain things you have to do to essentially create a credential around, qualifications in all sorts of professions. And so they are that body who's essentially doing it. The orthopedic one was the first one. There's future talk about other ones, rehab, these other aspects coming up. And, for those who have really, quote, specialized, and what I mean by that is maybe the large majority of their employed position is eval and diagnosis within an orthopedic setting. That is where, not that they can't or won't or don't do rehab, but it's not their main priority in their job as compared to someone who's
Mm-hmm.
working in a high school, college, professional setting. You're doing a lot of everything. And so it doesn't take down one or the other. It just says this person spends the majority of their time doing this one thing or one or two things compared to the 5 or 6 things that was built within our capacity. And so then it kind of puts what some would say credibility to that focused work. We all ATs have a strong background in orthopedics. That doesn't downgrade anything, but there are people who have excelled and have a lot deeper knowledge of orthopedics based upon what they do on the daily in their career. So that's the difference that way. So it's not cutting anybody down. It's just saying there's a recognition in some of the work and progression people have done within this area. And this is one way to recognize it. The problem is, and I'm hopeful in the future, it's not quite recognized outside of our profession at the same time either. So the hope is like, yeah, I've got this credential that says I can do all these things or I have this level of knowledge. But if your institution doesn't recognize it, it doesn't really promote higher salary, higher pay, or any sort of like, employment edge that you're trying to get by, when you're going against somebody else, right?
So with the specialty certifications, they were selling us big time that this was supposed to help elevate on the business aspect. But if people aren't recognizing it or it's too new of a certification, I felt like it was an extra step since we already have these skills within our certification. I can
Yeah.
see that it brings light to specific things like you were talking about, but it just at the end of the day seems a little redundant, and from what you're giving feedback on is it's not even widely accepted. So is there a purpose to get more certifications, do you see, that are specialized, or how do you what feedback would you provide on going forward with these specialty certifications?
I do think there's value because I think it creates a call out of somebody's experiences and depth of knowledge in a certain area. I find there's value to that.
Mm-hmm.
Because in the situation that if I was to change my current employment status and go into a role as an AT where I am doing rehab focused work, nobody's going to be happy with that because I haven't done that in over a decade. Right. And so like then somebody who's been doing it for 15, 20 years is going to be running circles around me. You're like, what does this guy know? Yes, we know he's got this base of education because of the credential, but like, is he really going to be helping us? I would think I'd probably not be helping. Right. And so it might be harder for me to then get a job, to be completely honest, from that standpoint. At the same time, the hope is that it would help somebody get a job if it's going to create an edge for somebody who might be more qualified or have more experience or better suited for that role that they're going for. Again, it doesn't speak down against anybody who doesn't have it. That's not what it's doing. It's just trying to recognize the extra work and focus that they put into in their career and how they can apply it to that role, right? And so, someone who has worked within a college setting has so much more global experience than I do as far as what I've done in my career. But if you were then to put that person in a focused orthopedic role, say with a joint replacement clinic, right? And how that scenario and clinic model rolls, it's going to be really, really tough, right? Because it doesn't quite translate the same. Just like I said, like if I was to change my current role and go the other way, it also isn't going to translate. So it gives an opportunity for people to have some recognition of their skills that they have gained over time and focused on. And so I think in time, the BOC is working together, the NHA is working together, the KD is working together, these other organizations like AATE, ATPPS, like we're trying to elevate the profession together and trying to push these things that will help give people future opportunity. How in the end it is recognized and hopefully the compensation is realized with that validity with the credential is to be determined, but hopefully those all things go up together, as it happens. And so I'm excited to see what the BOC is doing. Like we support them. I support them personally in that endeavor. But they'll still excuse me, I can't talk. I still think that there's opportunity for this to be, a total benefit for the entire profession.
You work hard. You train hard. You take care of everyone else. But when was the last time you treated yourself? That's where Source Soap comes in. Created by athletes for athletes, Source Soap is an all-natural recovery soap that helps wash away soreness, inflammation, and fatigue. With ingredients like peppermint, eucalyptus, and activated charcoal, it's basically self-care disguised as a shower. Whether it's after a long training session, a tournament weekend, or just a tough day, Source Soap helps you reset, recover, and smell amazing. Because taking care of your body shouldn't stop when you leave the gym. So go ahead, treat yourself. Head to sourcesoap.com and use the code TTB15. That's TTB15 for 15% off your order. Because recovery starts with you.
Now, more than ever, athletic trainers are becoming inundated with the growing volumes and sources of data surrounding clinical injury management. In fact, the purpose of data has changed. Whether it's pre-participation examinations, electronic medical records, concussion management, nutrition, or wearable devices, athletic trainers are constantly faced with new and complicated challenges interpreting data to drive patient care outcomes, reduce injury rates, and show practitioner value. To get ahead of this change, athletic training departments turn to Preventix, a data analytics solution provider. With over 25 years of athletic training and clinical data experience, Preventix empowers athletic training and sports medicine organizations with tools necessary to quantify the impact of care interventions on patient success and outcomes. As a trusted partner, Preventix works with you to build a strategy that addresses your specific pain points, integrating all your data sources, providing clean, reliable data, dashboards, and metrics that can be immediately accessed by stakeholders at the point of care. Don't let messy, siloed data continue to negatively impact your care delivery initiatives and practitioner value. Unlock the power of your clinical data today. Visit Preventix.com for more information. Preventix.com. So we come into the profession at the entry level, and then these would kind of replace a specialized track within a master's program. Possibly it's a concentration area is what these certifications are supposed to do. Would you say that?
Yeah, I mean, here, look at the regular just healthcare model, right? Let's talk about just med school. People go to med school, right? They become a doctor, so that's us becoming an AT in the siloed equivalents, right? And then they do
Hmm.
residency, right? So they want to go into orthopedics, they want to go into family medicine, they want to go to internal medicine. Then they spend a few years focusing just on that alone. So that's residency. So now somebody has gone through, now they know orthopedics specifically within healthcare, right? And
Hmm.
then, depending on what you want to do, there's what you call a fellowship. Now, in the orthopedic world, I don't want to just know orthopedics. I want to be a joint surgeon. I want to be a sports surgeon. I want to do pediatrics, right? And so you continue to focalize your specialty as your career goes. And so that's kind of no different than the same trajectory as what we're doing. So you come in as an AT, entry level, you've learned how to not harm somebody, essentially, do no harm, but with these other tools. And now you're trying to figure out where you want to go with your career. Residencies are an option to be like, hey, this is an area I want to expand in, I want to grow in, I want to understand. And so, again, traditionally, orthopedics has been that launching point. There are rehab ones, there are, quote, pediatric ones, which is really kind of a high school or junior high type of a level of patient care, right? I don't want to call them athlete, but patient care, right, in that population, because how you're going to treat somebody who's an adolescent versus somebody who is a skeleton mature adult are different, right? There's different things to worry about. And so I think it all depends on what people want to do. I think understanding that there are options is kind of the uphill climb right now for the profession of like, hey, like there's a lot of employment opportunities, but if you don't quite know what you want to do, or if you have interest in something specifically, there are ways to go get a very specific focused like opportunity in those areas.
Okay, so we're opening up more pathways of specialization and being able to create more direction for athletic trainers to get to their professional setting that they want to be, is basically what you're saying.
Yeah, and just because you go through a residency, say it's in orthopedics as an example, that doesn't mean that you have to work in a physician practice. You can take
Yeah.
that with you and say, I want to go work in the collegiate or high school or different setting that's separate from physician practice. You can still take all those skills with you and bring them over, right? Like, so that doesn't change. It
Hmm.
just adds more to your education, your focus, your background to then guide you where you want to go, right? And so I would say a lot of people do stay, at least for a period of time, within that setting if they went through a residency, but by no means do you have to, or, you can take it and go somewhere else by all means. People should if they want to.
Yeah. So in the hospital setting at Pennsylvania Hospital, for my example, so we had the orthopedic group, the athletic trainers working in the clinic, but then we also had the outreach athletic trainers. Would
Mhm.
that technically still be part of the physician's practice, or is that separate to an extent, or
Yeah,
a
I mean,
cousin
if
or
you're
stepchild?
no, first off, there's no step down or step up in comparison. Those are just two different roles. That's all that is. Now, it is common
Okay.
to have a hybrid role, right? To be like, hey, I work part time in the clinic and I work part time in more of that outreach setting. That happens all across the country, and that's more of a probably a business decision from like a model standpoint, employment model standpoint for that institution, so that they don't have to have outreach ATs as its own model, and then ATs in the practice, that model. But I've seen it both ways. At St. Luke's, where I worked at previously, we had a huge outreach program, right? And some of them had some experience or would occasionally help out in clinic, but they were not required to, right? And then you had other people who were in the clinic full time, and if they wanted to be a part of the outreach events, they had the opportunity to, but that wasn't required of them because that wasn't their actual job description. And so, you know, there's no step down, step up like I was mentioning. These are not one is better than the other. This is two different settings, two different responsibilities, two different approaches, and it's a matter of like, what do you want to do and what do you want to be a part of? And so I knew many people in the clinic who still did outreach things because they quote wanted to keep their hands dirty, right? Because that's the foundation of where we all came from, right? And so
Hmm.
it's always fun to kind of get that feeling again, but at the same time, some people don't want it and they've moved on, right? Or people love that full go. They're not doing anything different. That's their career and they are happy, and that's all that matters.
Yeah. Well, from the business side of it, I've talked to many people, and even just when I was at Pennsylvania trying to elevate the responsibilities of athletic trainers and educate what we could actually do. The ROI and all that plays a big picture into it. And I think that was the hardest part is right after I left, they got rid of the outreach program for the high schools in the Philadelphia area.
Mm-hmm.
I don't know if it was they lost the contract or fiscally it didn't make sense because athletic trainers were so efficient at their jobs. They weren't necessarily referring as much as they probably should have,
Yeah.
which there's obviously ethical questions around that of, are we just sending to bill or is it a needed imaging or evaluation or second opinion, whatever it may be. So those are some of the hardships I've seen with athletic trainers being associated as outreach providers for the hospital. I think it creates great marketing and community outreach, and I think that's one of the ways that hospitals should kind of look at athletic
Yeah.
trainers in the whole business model portion of it. But like you said, generating 3 leads a week pays for that salary, which I think that's where we have trouble in the traditional setting is the balancing of numbers at the end of the day. We're really a cost to the departments.
Mm-hmm.
And I just want to see if you had any input on that from the hospital setting of not just becoming another expense at the end of the day. When I was trying to elevate, it was, well, we can fit into those non-billable sessions that the PAs or the physicians aren't going to necessarily bill insurance for, of post-surgical checks,
Mm-hmm.
those different, or the note taking, like you said, or scribing, I guess is what they call it.
Yeah.
But what are your thoughts on the business model and how to strengthen the contributions of athletic trainers to the physician's practice?
Well, I think the closer you can align from an interprofessional standpoint, the closer you can align with learning opportunities between both groups, the better everyone works together. Because the thing is you don't want to feel like there's a step in visibility of one position over another being elevated compared to the other. Because it's not that. Again, like I mentioned, those are just two different jobs. But if you bring
Mm-hmm.
in those who are in the outreach setting, if there's education happening in the clinic, right, by all means, you should include that whole group in there so that they can understand what you're doing. Also, kind of like how the clinic side thinks and processes, but just generally education. Same thing for the outreach deal. If there's certain professional learning opportunities that should be done to educate the clinic staff so they know what's happening on that side, that should be done. They should be kind of collectively done together. That also
Yeah.
helps breed good commonality and teamwork amongst it, because being in the clinic and having someone out at one of the high schools and say your doc, like your team doc and the doc you work with in clinic are the same person, you are continually an interdisciplinary team working together on how to get your patients taken care of, right? So that's
Yeah.
where the connection comes in from the clinic side to the outreach side between the doc and the health system. The business side, that's a very complicated and tough conversation because it is more often an expense than it is anything else. It's a cost center. But the question is, what's your goals? What's your mission and vision from the institution? And then that can help justify what you're doing. If you're trying to be a leader in healthcare in the community, it only makes sense to have an outreach program that is vast and covering, you know, not just athletics, but community help for those events, right? And so it makes the marketing thing you said. I mean, that's what it is. That's marketing for the hospital or for the practice that you're working for. But at the same time, they see the business name, the logo on the chest, but they meet Shelby out there at the event, right? Shelby takes great care
Mm-hmm.
of them at the event. They also get them into Dr. Smith, right, who Tim works for. Tim then says, "Yeah, Shelby and we're like this. Like, I know she already let me know what's happening. We got an appointment for you. We do this, we do that. We got you in." And then the doc is like, "Yeah, hey, Shelby said this happened. Tim said this happened. This is kind of the direction we're going. Now let's talk between physician and patient, and then continuity of care continues even after the fact, right?" And so, if you are trying to make sure you take care of the community, which means continuity of care is at the utmost, so everyone on the team is working together, then everybody is succeeding that way too. The indirect aspect of it, you see, little Johnny, right, who hurt his knee. Well, if the care for Johnny is second to none, then mom and dad are likely to also become patients when they're in a similar situation, or refer friends or family, right? And so there's this
Mhm.
ongoing, like, when you have this visibility in the community of competent and high level care, then like people are like, I want to be a part of that. And then it becomes, you're integrated, right? And then it's hard to put a cost value on that, other than, yeah, there's a cost to put it out there, but here's all this indirect, like, downstream business model revenue essentially that comes in, but patients are being taken care of. And so again, you want both those things to happen at the same time. I don't know what the answer is to make a quote profit making outreach program. I'm also probably not the person to answer that question, because there's probably other people who can have so much further insight than I. And I would love to learn what that is. But we know that there are really big outreach programs and there are small outreach programs, and some have done really well and some have not done well. And so I think it all depends on from the top down. If everyone shares the same vision, then it's easier to have those conversations. If they don't share the vision and they're all about the dollar from the top, it's going to be a tough road, not only just for having a program, but hiring new people and expanding. So those all go together.
Yeah. Well, that's where, we get segmented into the departments because we're associated with them. But I feel that there's a missing step in the departments of the marketing budget needs to go into this position too. I don't know how that works in a business way,
Yeah.
but like you just explained, is it's a trickle down, is you have people out in the community, they're talking about your services, they're advertising by giving advice. And if they did it a next step, they're providing educational courses to the students or even the parents, holding those community events where this is what we can provide you as a healthcare system at our hospital. And it's one of those questions I don't think we'll come up with the answer at the end of this podcast, but it's just trying to, how do we interweave that? Because I hate that hospitals are losing athletic trainers to their outreach programs because it's not generating money. So how do you fix that problem? Because it's necessary. And I think that's the most efficient system at the end of the day, is if you're associated with a hospital. But yeah, I don't, also trying to figure out how to get them compensated more, because I don't think the outreach
Yeah.
positions are necessarily getting compensated for all that they're actually doing. But if they're not generating revenue,
Yeah.
how do you balance that out?
That's putting it lightly, right? I mean, they do so much more than what they're asked to or expected to,
Yeah.
and I think everybody deserves more than what they're getting. The question is, how do you drive that value? How do you realize that value from a dollar and cent standpoint? And so again, I'm not the expert in that, and so I think the people who run large outreach programs should be someone you consider actually on future podcasts. I've got someone to recommend for you, actually. Um,
Perfect. Send me their
I'll even
name.
call it out. I'll call it out here too. His name's Kip Dribnak. He's at St. Luke's here in Boise, and he
I
is he
like
has been.
this.
Do you know Kip? Yeah, Kip's
Yes, I've been trying
phenomenal.
to get him to come on.
Oh, well, I'll shoot him a text too. Anyways, he doesn't like to talk about himself, which just adds more to just the
Yes.
person he is. But he's got so much value to share on that realm, and his group is in parallel, like, with the large clinical AT group at Luke's at the same time. And so
Mm-hmm.
he has seen the evolution of the clinic side at Luke's and the evolution of his own outreach program at Luke's. And so just to speak highly of Kip, he's someone that would be wonderful to be on your podcast in the future.
Yes, I have asked him multiple times, but he's always running around internationally and everything
I mean,
else. So
that sounds about right. Him and the U.S. soccer opportunities are never in a shortage from that standpoint. So, but even he's, again, since we're on this topic, Kevin Taylor is one of his right hand people. Um, he's got a staff of leaders that could also be wonderful to bring on. So
yeah,
even if Kip can't make it, maybe he can recommend somebody on his team to be part of it.
yeah, definitely connect me and I will host them
Happy to.
gladly.
Yeah.
Uh, so we talked a little bit about the finances, some of the billing. How would you describe athletic trainers add value to the physician's practice compared to traditional sports medicine or athletic settings?
I think I don't want to compare. One is not better than the other, but to answer the
No.
question on the value from that standpoint, is the continuity of care is different from that standpoint. So, say you're working with it could be non-operative or operative provider, doesn't matter, but you see them when they first come in. You're with them through the entire kind of course of their treatment. Say they go on to surgery, and you work for a non-operative side, you are now connecting them with the operative side, like a warm handoff of like, here's this patient situation, here's what's happening, here's what we've talked to them about, and then you pass them off. Then you're especially if there's other ATs in there, you're working as a team. Okay, now I'm the AT for the surgeon. The other ATs gave me the insight of this patient before I ever met this patient. The patient comes back, hey, you talked to Tim at this clinic and this provider, and we've talked about this, and this is their story that I'm aware of, and so they're already like, holy cow, like they know who I am and what my problems are or what needs to be addressed, right? And then it's okay. Now we're having surgery. Say it's an ACL. Hey, in this age group, here's the common graft options, whether it's your tissue or we're going to do allograft. Here's what the doctor usually goes with based upon these things. I want to just put some information out to you, not telling you what to do or what to choose, but like, here's the information that he's also going to present to you. So you're already starting to like lead into like the direction it's going. And then before the provider comes in, you're like, hey, here's little Johnny. They saw Dr. Smith before in non-operative. Here's their assessment. Here's their diagnosis. Here's what I've talked to them about for ACL surgery. They're going to ask me, do they want surgery? Like, yeah, they do. Any sort of graft kind of thoughts? Oh, they probably want to do autograft. They're young. The data says that that's the more appropriate direction anyways. Cool. They go in. They then also recap all the conversations that have happened around their care for that patient, then kind of hone in on, yep, this is what's happening. Here's your diagnosis. Here's what I do. Here's what I recommend. And you kind of continue that way. Okay, sign up for surgery. Tim's going to come back in, right? Talk to you, answer additional questions that you have, sign you up for surgery. Oh, by the way, depending on the person, maybe Tim is also going to be in your surgery along with the PA or without the PA or just a part of the team, right? So now you have this familiar face that is kind of constantly a part of everything alongside the physician. You're there for surgery. You're there for their first post-op appointment, right? You're doing suture checks or just incision checks and range of motion stuff. The doc pops in, make sure everything's good to go, as long as there's no complications or concerns otherwise. Answer any additional questions after the doc leaves. Get them on to the next one, and then 3 months later, 6 months later, they're doing all their rehab, right? Whether it's with their AT at the high school or the college or the private practice down the street, doesn't matter, but kind of working all together. So you've now been a part of that entire like injury standpoint, operative discussion, surgery happening, post-op care, and continues, right? And so the patient satisfaction, the physician satisfaction, right? Those things are all at a all-time high from there because of everything that's going smoothly, knock on wood, in a perfect world, right? And then it's from there is like, how many more new patients can you see? How many more people can you fit in? That's the business side. And so when you see more patients and patients are happy, everybody grows together that way, right? And so then it becomes, it's Dr. Smith and the AT Tim and the PA John and like whoever and the MA Ashley. It's a collective team, right? You are added to the team. You're not replacing anybody on the team. Not that that doesn't happen. We understand that there are times where professionals get replaced by an AT, and that has led to some rifts. I get it. There's scope creep. There's other conversations that happen within all of this. But if you come at the mindset of, I'm coming to add to the team, to help the team, where we all go together, that's the approach. The other stuff is out of your control at times. Whether people leave or don't like the model and they want something different, and they leave and go on from there. That's going to happen. Happens all the time. But again, if you're going in there to make sure the patient's taken care of, that you are working at the top of your scope based upon what your institution and your state allows, and the physician's happy, and then administration's happy, like that's the route of value.
Yeah. So what skills translate the best into this environment as an athletic trainer, would you say?
Honestly, your ability to talk to a patient. Just being able to be like, have a conversation with somebody we are used to seeing patients slash athletes slash whoever we're treating at their lowest, a little bit of just impromptu counseling that goes with it, and then literally to be able to talk to a stranger. That it's a innate thing about being an AT that you've had to learn to do. Whether you're a people person or not, you have to learn to talk to people. And if you can talk
Yeah.
to people, you can connect with them. And once you connect with them, you build trust and all the other like formality and education that comes around with like understanding their diagnosis and the treatment plan that comes with time. And there's also the kind of this innate drive to want to do better and to do more by most ATs. And so who doesn't like somebody who's proactive and wanting to like push harder, right? There are people who have tried to push too hard or push beyond the limits of our scope, and that sometimes gets your hand slapped, right, from a professional scope creep standpoint. But you're not; it's never going to be perfect either. So I think that is an easy answer as far as what translates, and that's just being an AT is an automatic translation from there, and then you can learn all the other stuff.
Yeah. What are some of the biggest misconceptions about athletic trainers working in the physician setting?
Oh boy. By the AT or by the people the AT is working with?
Either or, I guess.
Well, to be honest, I think going on to the comment of wanting to drive and wanting to push, you do get to learn next to physicians, and sometimes you feel like maybe you could be or are that person, and you're not, and so it's kind of there's still like a lane to kind of understand and keep in consideration at times, and so that's where like administration can maybe have a bad taste in their mouth based upon an AT who is pushing outside their lane, and not necessarily an invalid push, but maybe the way they went about it wasn't the right approach, right? And so uh, just maintaining that thought process. You're a part of the team. You're not higher or lower than anybody, but everyone has their role to do, and amongst that role is to help everybody else around you. And so there's some interpersonal opportunities to improve that would then just overall improve the perception of ATs within the setting too. It's never gonna be perfect. You're gonna have outliers that are pushing too hard. You also have outliers that are like they're not doing enough. Like let's go. Like there's more to do. Like you're doing the bare minimum. We need to push. And then you have a lot of people in between who are like learning, growing, pushing, helping everybody else around them. There's a bell curve that way.
Yeah. Well, and I think it's the breadth of knowledge that we have because we're there at evaluation, we're there at treatment, we're there at return to play. And I think the physicians sometimes miss those parts. They have the general overview, but we actually are the ones that implement it most of the time. So I
Mm-hmm.
know an example working with the hand doctors, we had a patient that injured her thumb and they were basically going to amputate it at that point, and they were trying to figure out other ways to break up the scar tissue, and it was trying to educate them about dry needling and the effects of that and how it can help with all that, and they just had no knowledge of it. They've heard of it, but they didn't understand the physiology behind it or the application on it. And it was really
Yeah.
difficult of like, okay, I'm trying to save this girl's thumb. Like, wouldn't you want to throw anything else at it and like
Yeah.
find the perfect person to do that? I mean, in Pennsylvania, I couldn't do the dry needling or else we would have figured it out. But,
Right.
Trying to connect them with other resources, because I think
Mm-hmm.
some doctors get stuck on the trying to be conservative, but then there's the surgical cut them open, and there's a lot of mediation between that. And I think some doctors are doing better, but there's still some that their caseload is, got to bill it out, got to go get them better. This is what the patient wants, and they don't know how to
Yeah.
educate on the other options sometimes.
Yeah, there's an unfortunate truth to that, and I don't think I want to put myself in a spot to call out physicians doing or not doing the right thing. Although I think there are factors that lead to decision making, right, one way or the
Yeah.
other. Um, and so I think from there it's about advocating for your patient and doing everything in your power to do that. And if you can educate other people around you, and that leads to advocating for your patient, that's the best way around it.
Yeah. And there's so many layers of third-party reimbursement and all that, and what can actually
Mm-hmm.
be done at the end of the day. I think that's one of the things athletic trainers still haven't really globbed onto, is the restrictions that come with third party and being, fully reimbursed for the skills that you're providing. I don't think you get to be as inventive with your therapies or your programming with those kind of parameters on top of you.
Yeah, there's a lot of impacts that you have no control over. You just got to understand it and learn around it.
Yeah. So I also want to talk about the NATA and the relationship between the Physicians Society. I know it's been an evolution, and I think we're on the ups, but why do we need these societies or specific associations within NATA, and what does that do for the profession ultimately?
So it's a great question, and it's been an interesting time over the last 8 to 10 years going through this. And what I can say, it is on the up right now, and that's the most productive part about this and optimistic part about this. There's new leadership at the NATA, and there's new direction. And my understanding is that they're open to anything and everything to kind of further elevate ATs and not just membership, but the profession itself. And I think that's where maybe the NHA has lost some people. And this whole question and podcast episode should not be and is not about what the NHA is doing or not doing. But the thing is communication's open from our side to them and several of the other societies. And I think when you have the goal of elevating athletic trainers, not just members of your group, that's where people will start to turn their head and say, oh, okay, there's more interest here, or there's more opportunity here, and let's revisit, kind of how me as a profession would engage with any of these organizations. And so, our society is focused on those who work in this setting and trying to give you all the content and resources available to it. That doesn't mean other people can't or other organizations can't do that too. That's what we do, right? And so, if those can collectively work together, awesome, right? As long as we're not trying to compete for members, or which is really the dollar, then we're doing the wrong reason, regardless. But if we're doing it for the collective profession, then that's where there's opportunity for everybody to kind of rise together, and just creates more avenues of support, really, right? And so, NATA is a large organization, and I'm still an NATA member. That's never changed. I do feel that you can't really have a true voice to what they're doing or not doing or how to make things better if you're not a member. But at the same time, my focus has been, a member and an active board member of this organization for the last several years too. And so our goal is to benefit ATs who want to work in this setting and give them everything that they need and help them out. And do we have all the answers to that? Sure don't. But we're also trying to learn and figure it out. But the collaborative effect of these organizations working together from an advocacy standpoint is huge, because everyone hears what's going to happen differently, sooner, faster, or delayed compared to other people. So if our organization finds something out that's going to impact ATs, it helps us to then tell other people, especially other AT organizations, it's happening, because it also could impact them, right? And at the same time, if your mission is to positively impact ATs, you're going to want to know that and figure out how can we collectively work together, on this deal. Have a similar message, have a similar form of support, whatever you want to call it, where again, it's elevating the AT, not necessarily who's a member or not a member.
Yeah. Well, and I think the specialty associations, it's easier for them to keep their nose to the ground on what's happening and then be able to present it up to the NATA as things happen. And even as you mentioned before, even in the physician's practice, you guys still have limitations on the broad strokes that you can do. It depends on the state's practice act and what the hospital system's willing to do. So, it's the collaborative effort and having multiple energies being around it to enhance it at the end of the day. Because, the Physicians Society has maybe a little bit different concentration than what the NATA is possibly doing for the physician athletic training setting at the end of the day. So it's coming at it from all angles and strengthening it from, testing it in different realms and different situations.
Yeah, and I don't want to focus on it, it's. I don't feel that this is a hierarchy of any sort, and I
Yeah.
also don't want the perception that there's a hierarchy. Like our society, despite how it was born out of, has gotten to a size that like we're not going anywhere anytime soon, and so we just want to be able to share the same space and help all the ATs where we can help out, basically. And so it's not a matter of sharing up or down; it's sharing across. And you're like, hey, these are our peer organizations. These are people who we have similar strategic interests in doing this, and so like there's things that we have found out that has been impactful to like industrial or performing arts or whatever else. Like, hey, we found this out. Are you guys aware of it? And oftentimes, like, yeah, we got it. Cool. Or it's like, oh, we had no idea. Thank you for sharing. Okay, cool. Let's make sure everybody else knows too. And how can we maybe even send a letter of support as a collective group, and or send it individually with the same message, to the groups that it needs to go to. And so it's really sharing across the table, not above or below.
Yeah. Nope, that's a good way to put it.
Yeah.
Well, what else can you tell me about the Physician Society that we missed? Or was that a pretty good encompassing picture?
Yeah, I think it's a good encompassing picture. I think we went on a couple of tangents that I wasn't expecting, but I thought they're all tied together. They're all tied together. So it's like it makes sense to kind of talk about different things because there's crossovers and there's benefits by doing so. But
Yeah.
if people are interested in understanding more about how to get into the physician practice setting as an AT or how to advance what they're currently doing to do more, maybe they want to push their responsibilities or to maybe promote themselves in the future for other opportunities, our organization is a great way to learn from a formal content standpoint. But the network is probably more even just as more impactful is like the people. And so being able to meet people who are in similar roles or roles that you want to be in is a great opportunity, to get in that network and have those connections and have someone to call and be like, hey, I got a question or an issue. And they're like, yeah, here's what I did. How can that help
Yeah.
you? And so that's where the long-term value is. It isn't just the content, but it's the network amongst the membership who are in there trying to help everybody out.
Yeah, definitely. Well, thank you so much for being on, and please let me know if the Physicians Society has any new projects or anything that they want to talk about and get pushed out, and I'd be happy to host you guys again.
Thanks for having me, Shelby. I really appreciate it.
Yeah, no problem.
Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.